We believe that the PSC plan, as has been communicated to us, is that they will go ahead with implementation of their plan for completing the merge, which they have informed us that they had been doing for the past 3 to 4 years now. So completing the match includes bringing the ministry, including the doctors, under the PSC general pay scale, PSC remunerations, SPE overtime work or work performed after hours, and there are also other PSC working conditions. There has been a number of meetings since March of this year when PSC started to inform through the ministry that the whole ministry will now, including doctors, will be brought under PSC working conditions. Initially it was us, only the doctors working inside the ministry, that sat down with the ministry, as in the executive director general and some of the management, to clarify PSC's position. It was obvious that, and also the ministry assured us that they would, not only they had given us time to sit down and discuss and clarify and bring our views, but that they would support in whatever way that they thought was reasonable our request to the PSC. So that happened. We were copied in communication that reflected the Director General asking on our behalf on some of the things that we had asked for. So after that initial meeting, and of course there were consequent responses from PSC, and it was becoming more obvious and more clearer. The intention of PSC was that whatever they had brought through the ministry was what was going to be implemented. So there are a number of issues, one of which was the medical doctor's pay scale that was approved by the government then through a lot of hard work that involved also the Samoa Medical Association. That pay scale, as far as we are concerned, is the one that's being used now up to this day for the doctors. The transition from NHS to being remerged again, that transition took place since 2018-19, and now PSC says that now they want to complete the transition and move everyone totally under PSC working conditions. The ministry, as we listen to them, they believe that they have done what they could in the circumstance that they are in. And we recognized this 2 months ago and knew that we had gone through the proper channel to try and come to some agreements or some positive negotiation with the ministry, and they admitted that they could only do so much. So we knew that the next pathway for us to take was to go to the Samoa Medical Association. So that's where it started with the process. That's where Medical Association came in. And since then, we, the workforce, or the doctors inside the ministry, have been working together with the Medical Association, and maybe one or two other meetings that we sat down together with the ministry. A lot of things have changed in the last 2 or 3 weeks, quickly changed, and we believe this is part of the negotiations and back and forth that have been going on. And some of these have been look promising, but there are others that are not, that we think that needs to be, that we want to ask that they fulfill, as has been expressed by the President, that a lot of these recent developments or progress in the negotiations is mostly through meetings and therefore verbal, and we understand that unless it's in writing and documented, that we can't really believe that it's going to all happen as has been discussed. So that's a concern by many of us. PSC, when it started to bring the determinations that they've done to the ministry, initially came and addressed only the senior level doctors and did not include anything to do with the registrar and house surgeons, which is the rest of the workforce. And it's now become obvious that because everyone expressed the concern, very serious concerns, that that there may be serious consequences for the rest of the workforce if everyone was to just focus on the senior and not address the junior or the rest of the workforce as far as the doctors were concerned. So that's still, that part is one of the important part of the negotiation that we wanted to be very well documented. It was not until recently, just like in the past or yesterday, that there have now been offers of direct appointments. So that was something that never came up before. We understand the PSC process of recruitment, even though it's last minute and it seems like a rushed thing to be brought to the table. But we have looked on the good side of this. But there are some areas and some aspects of this that we need to look at. We haven't seen any contracts, and we understand PSC is when ministry staff have contracts, they are directly done with the PSC and not with the ministry. So that's just an example of something that's still to be worked out, other than the majority of the workforce who are registrars and house surgeons. There are about 92 doctors altogether in the hospital, and majority of them are registrars and house surgeons. And that will make up probably 2/3 of the workforce, and there are so much fewer senior doctors. And that's a big concern for us, because there are all of them, or majority of them, have not been realigned as had been worked on, and the process required for appraisals and for documentations to. So that's also another aspect of what we are hoping that now, and we'll wait and see, and requesting that this be put in writing, because all of our colleagues are very much concerned. Separation into NHS and MOH happened in 2006. NHS, as you are all aware, is a state-owned enterprise, and it so happened the working conditions, of course, in SOE is differs in some aspects, including the remunerations of overtimes. So the way it has been done is that the overtime rate is based on the base salary. So it differs for everyone. So depending on what the base salary is, there's a formula that calculates what the overtime rate is. And therefore the times 1.5 and the times 2 concept is applied. For PSC, of course, as you may all be aware, it's part of its working conditions that the remuneration for any overtime hours worked is different. They have a set blanket rate, regardless whether you are a doctor or nurse or another health professional or in any ministry. That for times 1.5 is $13, I believe, and times 2 is just over 17 tala. So those were the changes that they wanted to be fully implemented. But I want to also add that is one of the positive response that they brought to the table since recently. I believe it's this week in the discussions and meetings that were held this week, then they conveyed that for all doctors who are not contracted, by BSc standard, any doctor below the salary scale of 70,000 will continue as is the current process or way of remuneration for overtime hours worked. So that is one positive outcome that we are grateful for and acknowledge the PSC for having come up with this. For senior doctors, anyone above 70,000, according to PSC working condition, they must be on contract or contracted. And for everyone on contract, they will be offered a responsibility allowance, and that comes in the form of percentages of the base salary. And the percentages that they've offered ranges from 40 to 60%. There's another outstanding issue because some of us were on contracts, only a few of us. And that's something that we are told that will be, end of contracts. And we have had contract variation. We signed up with PSC for 2 or more years now, contract variations after our NHS contracts were invalid. So that's also another that we are waiting on. But it's coming to me to say this because I did not listen to the parliamentary session last night, but I heard vaguely, and I could know from the morale of the doctors today when we came to work today and to the meeting that we had, that there is a big question about how did doctors earn so much, and figures were put out there in Parliament. I'd like to explain that, not because I want to defend, but to tell the truth, and then let the public hear and see for themselves. I believe it was after the last strike, after the strike in 2005, one of the benefits that was given to doctors at that time was an allowance of 100 tala per hour for any consultant or any specialist or any senior doctor who is called back to the hospital to do work after hours. As you would understand that the rostering of, or if you are not aware, there are rosters that are prepared by each department, and the roster is dependent on the number of doctors that are there, and also the skill level or their capability or the level of each doctor that are there. So the roster is prepared in such a way that there is a first on call and a second on call. The first on call is the registrar, or the house surgeon in some cases, or the house surgeon is another word for the intern. And the consultant or the senior doctor or the specialist usually perform the second on call. This is very important. We work normal hours. This is how the system has been. Way back into the MOH before there was a separation, and continues into NHS, and now it's continuing. This is the strategy that we ourselves came up with in order to cover the work during working hours and also cover the 16 hours every day. We do 8 hours, and then from 4 to 8 the next morning, that's the 16 hours. Because of the severe and the chronic shortage of doctors, especially senior doctors, and because we understand that in every workforce or situation, people or doctors have been leaving for very good reasons or other reasons, leaving the workforce. Unfortunately, the workforce from then up till now is remaining almost the same over the past 30 years. So there are areas in the hospital that are very busy and very high risk. I think, as you can see from media, sometimes of the publicity that involves patients in the hospital. And then it's the point being that in order to provide quality and safe service, there must be supervision, there must be support for the junior doctors when they are working. In high-risk areas in the hospital and very busy areas, amongst the doctors, we all know the different departments and how it differs from one into another. So with the severe shortage, some departments have only one senior doctor or consultant to support the junior doctors. And some may have 2. So you can see that there are 7 days a week. A consultant has to stand by, has the discretion to make the decision whether to remain at the hospital to cover the 16 hours or can go home and wait for that first on-call doctor to call. Because of how the workforce is, and because in high-risk areas, obstetric or maternity is one of the high-risk areas, and there are 2 lives. As doctors, we not only want to give the best service and safe service for the public, we also want to protect the junior doctors who are out there doing on call. So it is the discretion and the call of the senior doctor whether they are present at the hospital, not only to monitor, not only to supervise, but also to perform operations. No junior doctor can perform any operations on their own, unsupervised, and I feel we understand and agree on that. Surgical department is another very busy department, and it has had 1 and then 2 now senior surgeons who need to support the junior doctors. That has been the situation over basically the past 30 years. And to cover the 16 hours every day of the week for emergencies, for very sick patients, for complex cases, complicated cases. And I think we all know, SSB, we hear the comment that the health of the nation is not improving, it's getting worse. We agree we are able to detect and diagnose, and we are also told that there are too many patients are referred overseas. That's a result of non-communicable diseases, cancer, and now we are facing the realities of infectious diseases, pandemics, outbreaks. So as far as we are concerned, the workforce number is about the same. It's in a plateau. As far as we are concerned, the workload has gone up exponentially.
Ia na le toi fia so soania tu lava ile mta opulel overtime ilanga le wa fesilingia. Ele ai ma se o to of fesilingia to mana ambiani si overtime e lunga atu. Ole e whaftai atu foi le pisasi, sa ta tala mai foi la lato finangalo, na tamato to e talusanga sisi te lunga, le wa mai le onos full pasene, na a matal tolus fulu, ia fase fulu, le wa mai le onos full pasene. Ia mato foi o mato fia, ono lai lava tu mai lava noa, na paulea se mea fia whamanino. O le whaatinonga ese le whaatinonga o ngaluenga i to tono le whale mai ese departments. Whataita inga o la awa bea le whataita inga i fōma i tipi. O lea watu mai le avanloa o le a ese vaenga i to tonu lava le department lea fōma i tipi. E se le vaenga e ngafa maltalinga o safe too low po le ENT. E se le vaenga ngafa matao tonga tau manawa safe too low. O le lala au mai le kono karate e whaaululu ia ile si fōma i tipi i le ENT. I expect e whai fo ia ngā luenga tau tonga o manawa matulanga na so peo nei mena le sa tau toe tala noa ia ia mato pe o tala whea ngai ia remuneration nea o le la whaatino e le fōma e ngā luenga e stili atu e peo atu nui whafo e kwa specialized lava o low area lana pawana o ngā luenga te whaia ia aoi nei tātou e fesoso ani le si fōma i pe a o tūlanga e me se tau tonga after hours. So peo nei mata upuna le sa tau mana o mia ia sina taimi ia toi tala noa. Ma mātou ti tilo foi po o pe tau i le ia wā lava foi nei fōma ia la i tia whai mai. Ia o mai foi la tau i tūlanga ua leidunga a ua whea matala whea ngai a la foia a wā lava le remuneration o fōmai.